All right, hello everyone. We'll get started on today's topic, prescribing wheelchairs for pediatric clients. And once early on in my career at Sunrise Medical, I was giving a seminar, and this woman said she didn't have any experience with kids, and she said, "Don't worry, kids are just like small adults." And in lots of ways, that's very true. That the semantics of it, the technique of it is same. What we're trying to do is the same, but there's some very specific things that need to be considered when we're talking about pediatrics. For one, we know they're going to grow. They're going to grow, they're going to change. We also know that there's lots and lots of different people that are interacting with them, helping them along their way. And each of those different carers or stakeholders, if you will all have potentially very different motivations and goals. So it's always just a little bit trickier when we consider how do we provide a functional, usable, user-friendly wheelchair for pediatrics. But remember what we're trying to achieve here. What are our underlying goals? And it's really to get these kids active, participating in their environment, learning and developing as close to their able-bodied counterparts as they can. We can objectify that if we look at developmental milestones. We can look at them compared to what an able-bodied counterpart might be and where those milestones are. We're also very much more invested in creating functional postures and midline symmetric postures for our pediatrics, because we know if a 6-month-old, a 12-month-old, or 2-year-old starts developing a scoliosis, an obliquity, a rotation, that will get more dramatic as they age, as they get bigger, as their muscles get stronger, as gravity has more of a time to put its effect on them. So really, we're much more invested in that symmetric posture than maybe we are with our adult counterparts. At the end of the day, remember, we are trying to get these kiddos to learn, and the way that kids learn is by included and engaged and basically just doing. Whatever device, whatever mobility device that might be. There's lots and lots of studies out there. We've only got an hour today, so I won't burden you with those. But if you'd like me to send you some of the latest research on how movement and self-initiated movement facilitates motor development, cognitive development, and social skills, I'm very happy to share those with you. We've known that for decades, that in order to grow and develop, we really need to have facilitated movement, mobility in general. It's very, very important. And we also know that kids learn by doing, by playing, by touching, by feeling. So we need to allow them to investigate their world and participate, whether that be at a manual wheelchair level, a little scoot level, a power wheelchair, power assist. We need to facilitate that independent choice, that mobility. Underlining, our need to create those developmental milestones, to reach them, to facilitate inclusion. We also need to follow the golden rules. We still need to protect the skin, make sure that that stays intact. We need to manage tone, and by manage tone, it can be very different depending on what type of diagnosis we're talking about. It could be we're trying to increase low tone. It could be we're trying to decrease high tone. It could be we have real dystonic movements or very athetoid movements. So how can the kiddo get the best control of those body segments or those limbs to use in a functional manner? I spoke before about symmetry and investment in creating symmetry. Again, that's just because we know as this kiddo gets older and they're spending more and more time in gravity, that deformities will be harder to manage, they'll get bigger, and they can have catastrophic effects on function and even physiological functioning, like breathing, swallowing, and digestion. So remember, these are our golden rules, our must-haves in the system, all working together to really try and promote function, inclusion. The assessment process, very similar to what we do with an adult. We want to know what I consider their demographics. Basically, how old are they? What's their primary diagnosis? That'll give you a prognosis that'll allow you to anticipate what this child might be like, what their skills, what their functions, their abilities might be like in 3 or 5 years. We also want to know about any comorbidities, cognitive issues, cardiac issues, pulmonary issues, other weird chromosomal issues. Again, that's going to allow us to paint a picture about what the future might hold and what we need to accommodate or adjust for during the lifespan of this mobility equipment. I also like to have their approximate weight and 5 key measurements, again, so that we can get a very successful trial, make this process as efficient as possible. Those key measurements would be seated width, seated depth, lower leg length, seated height, chest width, and then probably sort of elbow height if I needed to support those upper extremities. Medications, many of these children will have lots and lots of medications. We want to focus on the ones that are going to affect their size, their shape, and their motor control, their posture, if you will. So typically that's your antispasmodic medications. I also want to know about any anti-seizure medications because that's a big safety issue if we have a kiddo that might have big seizures throughout the day or lose consciousness. The special needs category continues to get bigger and bigger and broader and probably more important. It used to be that we'd need to worry about having an oxygen tank holder, a suction machine, maybe they're tube feeding. Now maybe we need to think about a CPAP machine, a bilevel, a ventilator, orthotics, AFOs, turtle shell spinal braces, or if they've had some sort of hip surgery. Think about those orthoses. How long is the child going to wear them? Do they need to wear them all the time in the wheelchair or just periodically? Even some softer bracings like second skins. Those things are going to change a kiddo's size and shape and maybe their functionality, their control of their body segments. The other big category in this special needs is communication devices or tablets and iPhones, smartphones, that assistive technology category where they really need to have that device mounted securely and safely onto the chair because they use it periodically when they're at school or when they're at home. So can that thing be carried safely? Where does it get stowed during transportation? Is it safe on there? It won't fall off and break. Is it safe? Nobody will pinch it, won't get stolen. And is it in a location that's easy for them to use, no matter if we're doing a direct access to that device or maybe even perhaps integrating it into the power wheelchair electronics. So think about all those special needs. Can they come onto the mobility device? How will they be managed, both for use and also for stowage during transport? And then surgical history and plans for the future. Again, they may have lots of surgeries in the past. You want to specifically want to know about ones that are going to change their size, their joint range of motion, their active, their passive range of motion, their overall posture, position. Also very good to know about what plans might be in place. Are they going to get a feeding tube placed? Are they going to have other surgeries that will change their overall size, ranges of motion? Assessment goes on to sort of the physical items. What's their overall range of motion? Their strength, their tone, their ability to manage their spasticity. And in that spasticity, tone, abnormal reflexes category, I'll typically try and look at all three independently. Remember that spasticity is movement dependent, it's velocity dependent, whereas tone can be sort of at rest. Is it low tone, is a high tone? Is it more of a dystonic at the tone? And then you also have abnormal reflexes, which are movement patterns. So a particular head position, arm position, body position will trigger a set of motions, okay? So each of those might influence posture, especially functional posture, in a different way. Okay, so make sure you're getting the key factors in that physical category. Sensation is a very good indicator of comfort and also skin integrity. Will they get that trigger to move if they're uncomfortable? Also about tolerance of sitting. Skin integrity gives you an idea of their risk factors. We know that once somebody's had some sort of grade 1, grade 2 skin injury, that their skin is never as healthy again. So we'll just need to build that into the skin integrity, skin safety program. Cognition and behavior here, especially with children, we want to know what do they learn? How do they learn? Are they able to integrate things that they've learned into new situations? How many different things can they do at a time in terms of sequencing and retaining that information? It's also important to know about their judgment or their behavior. And, typically these things are two different things. Behavior is how a kid will express their emotions, typically, whereas judgment I think of as sort of safety awareness. Do they understand that stairs exist? Do they understand that elevator doors shut? That sort of thing. Okay, so make sure that you're looking at both, behavior, safety awareness in two different mechanisms. And then visual limitations, it's good to know what the children can see, perhaps what they can't see. Do they have field cuts? Do they have a neglect? Do they have hemianopsia? Is it very blurred? Is it skewed somehow? Some of the postures that we see, I often wonder, is that a visual sort of symptom? Do they have cortical vision loss, and that's sort of why their posture is the way it is in efforts of seeing better? So again, this is just allowing us to know better what to expect in terms of the child's abilities and probably even postures for the growing years. And then we want to consider what we need the mobility-based, the seating system to do. Where are they going to use it? In the home, what are the key needs for it? Are there particular space restrictions in terms of door widths, table heights, turning space in the bathroom, in the bedroom, height limitations for transfers in terms of both their transfer or parents lifting them in and out? Where are they going to use that system? What do they need it to do when they're in that location? And then we go outdoors. Are they anticipating going to the park, going to their brother's soccer match? Will it go to school? What kind of terrains will they come across when they're traveling in between all these different places? Think about inclines and ramps and steps. Think about surfaces, soft surfaces, or will it just be indoors, sort of very hard surfaces? Think about the distances that they expect it to travel, and who's going to move this thing? Is the child supposed to move it all the time? Or will a parent or a caregiver, friend be able to assist? How will they be able to assist? You need to think about the safety of the child as well as the safety of any of these caregivers. Another key tenet, I think, in pediatric assessment is how is this thing going to be transported? Will it be folded up and put into the boot of a car, and the child will go into a baby seat or a car seat? We know that the car seat is the safest place for the child, but we also have to think about, is that posture safe and secure there? Is the transfer over into that car seat safe for all included? Is it doable? Is it doable now? Is it doable 5 years from now? Is it doable all day? Okay. If they travel in the wheelchair itself, where are those tie downs? Is it crash tested? Is it easy to tie down the chair into the various different transportation things that the kiddo might use in terms of the bus going to school, going to friend's house, or the family van? And then the last category here is skills, abilities. What can the kiddo do? If we compared them to their able-bodied counterparts, what would they be able to do? What potentially could, would, should this kiddo be doing? Okay, if they had the right mobility device and seating system. Okay, so don't just think about what they're currently doing. but compare them to their age-appropriate kiddos and say, okay, potentially what might we be able to do if we had appropriate equipment. Broken this down, I think I covered most of these in the transport area. I guess I didn't say public transportation. If somebody were to use even a school bus or public transport, is that safe? Are there tie downs? Is entrance, exit from public transport safe? Again, for not only the child, but also the caregivers. The functional skills category, how are they getting in and out of the chair? Who does it? Is that safe? Is it safe long term? If they're sitting all day, who's providing them a position change and a pressure relief? How does that get done? How can we make sure that it's done? Because that's going to really help a kiddo's posture, and it'll help their comfort level, their tolerance for sitting in their chair. It'll help with their skin integrity. If the child is pushing the chair, have we thought about the efficiency, the effectiveness, the long-term sustainability of that push, the stability? Are they able to go all the different places that they need to go, that they potentially should be going? If a caregiver is pushing, is that safe, efficient, effective for them? Again, think about all the activities that will happen in this wheelchair and the locations that they'll happen. Have we maximized, or are we maximizing this mobility base's success in all these different activities and all these different areas? And then once you've had all those discussions, you sort of need to drill it down. You need to boil it down and come up with a priority list. I like to start with the problems. What are the 3 key problems? And we know that the key problems in terms of client is going to be sort of skin integrity, physiological functioning, breathing, swallowing, GI system, postural sustainability, functionality. With the client, the caregivers, their goal list in terms of priority might be very different. Might be, I need something that's going to collapse and go in and out of the boot because that's where my life is right now. Okay, so realize you may have a couple different goal lists at the beginning, and then you need to merge those and create one problem list, prioritized, and one goal list. And think about them in broad categories. What are you trying to achieve? Where and how are they going to do that? Who's going to help them do that? And then pointing towards that function and that comfort, make sure that you are looking at the posture for areas that could give you trouble for pressure or shear. We also really want to create midline, a nice symmetric posture, especially if they're a very young child. With that posture, you can also create a bit of a priority list of what you like most about the posture, what you want to make sure that you are keeping or sustaining, and what you like least about that posture. Some examples. Obviously, there's lots of problems with this. Probably 5-year-old being in a baby stroller. Okay, first of all, she has no independent choice. She has no independent mobility. And also, it's not providing her any postural support. So she's sort of collapsing into a thoracic kyphosis, posterior pelvic tilt, really reducing her lungs' ability to take a breath, reducing her ability to hold her head by herself, really reducing her ability to manage her secretions, manage her food, and also putting the pressure into some pretty pressure intolerant areas. Okay. So here, we'd really like to create a more upright posture, more sustainable posture, and also look towards, can we get a little bit more inclusion, a little bit more activity, engagement from the mobility device. Here we have a motor control and a spasticity abnormal reflex as our main issue. Here, when we get triggered, we get lots of extensor overflow. So we'll have lots of pressure, we'll have lots of shearing forces, and no stability really, and no control of those body segments for function. And then here, if we get her into a little bit different posture, now we are much quieter, and we have low trunk control, low head control. Okay. So can we find a posture that will allow her to start better controlling her body segments. And, less time triggering into a real extensor response. Here we've got no functionality. Although he's safe, he's comfortable, you can see we've got quite a bit of extensor overflow. He's got no ability to be included, no ability to go to school. And eventually a lot of these limbs, his legs, his back, his head position will all become very tight in this position, and it'll be difficult to sit. Okay. This is a little kiddo that spent the majority of the first couple of years of his life lying on the floor like this. Just long-term functionality and sustainability isn't there. So first things first, we'll take a look at the kiddo in supine. Supine, remember, is going to tell you what's possible. It gets gravity out of the equation, and it makes it very easy to look at what their body segment movements are, how hip movement, pelvis movement affects trunk location. You'll be able to very quickly see what range of motion of the hip, the knee, the ankle is, and its effect on the pelvis and the trunk. You'll want to consider tone spasticity, abnormal reflexes when you're moving these body segments around. Consider their comfort. Also want to look at their skin integrity. Make sure that if there are any red marks, you're making a note. If there's any open marks, if there's any high shearing sort of areas, that we make a note of that. This is easy to do when they're in supine. Just, sneak a look underneath the trousers, take a look underneath the shirt, okay? We'll also want to reduce or try and reduce any asymmetries that we might find. Remember that although you may have a really bad head position or a really big scoliosis, like Wyatt here, these asymmetries, their foundation is at the pelvis. So start the correction at the pelvis. You're building a foundation and building blocks above it and below it. So here, you'll see we've got a pelvic obliquity and a little bit of a rotation. He's just a little bit rotated forward on his right side. So you'll try and reduce that and see the effects on tone, on spasticity, and on that scoliosis, that trunk position. And he was nice and flexible, pretty much 100% here. You can see, kiddos, it's also easy to find your bony landmarks. So our ASISs are nearly level, even in the rotation plane. And then we can also see that although the muscles are tight on this side, he can come to neutral. Mom's helping us out a little bit there, okay? So he's correctable. Now we want to create that in his seating system. Okay. Start with the pelvis, see its effect above and below on body segments and on tone, spasticity, and on range. When we're talking about a wheelchair, we're very much invested in knowing what their hip flexion is, and it's hip flexion isolated from pelvic rotation. Once you get the amount of hip flexion that you'd like them to sit in, and for most of us that's going to be 90 degrees, you'll want to look at the amount of external internal rotation, abduction, adduction that's available with that amount of hip flexion. Make sure that if you've got 90 degrees of hip flexion and you're sort of to midline with their lower limb, that you all of a sudden haven't moved that rotation or that obliquity up the trunk. All of a sudden, man, they're really rotated at their trunk, or they've got a scoliosis that's developed. Okay, we want to see if you can get that pelvis in neutral and 90 degrees of hip flexion without affecting the trunk at all. Once you've done hip flexion, rotation, ABA deduction, then see what sort of knee extension, hamstring range of motion is available. And we're trying to figure out where we can put those foot plates. Then next, we want to look at the amount of dorsiflexion. With the lower limb in that position, do I have, sort of 90 degrees of dorsiflexion? Is it singular plane? Because I don't really want to create a lot of inversion or eversion. I want a nice foot platform so they can get proprioception and stability throughout that lower limb. Okay, very quickly we can scan. Make sure, just capture that you're not getting any movement to that pelvis. Especially with him, he had such an obliquity and a scoliosis. He's going to have a tendency to sort of rotate away from those corrections, just because his muscles and his body segments have gotten used to sitting like that. And then we'll move into the sitting assessment. And in sitting, now you've added gravity back in. Now we're back to the real world. Can we still make those corrections? Is it functional? Is it practical to make those reductions? What's happened to our scoliosis? Is the scoliosis still as correctable as it was without gravity in that supine assessment? Then we want to start looking at balance and functional balance. Because this is little Wyatt, he's got spina bifida. We'd love him to have a really nice symmetric position, posture, but we also know that we want him to be an independent manual wheelchair user, okay, most likely. So we start looking at that sitting balance, that functional balance. Okay, what does his trunk control, his upper limb control look like? I always start with the correction to the obliquity first. I can just put a towel or a piece of foam underneath whatever side, and then we can work on the rotations, work on the scoliosis, the kyphoses, above that nice and level pelvis. And here we've got, nice functional balance and a nice pushable sort of chair. Okay. So now let's take that same approach based on diagnoses. And because Wyatt had spina bifida, we'll start with spina bifida. Remember, sort of by definition, that spina bifida is non-progressive. It's a failure, sort of generalizing here, but a failure of the spinal column or the neural column to develop in utero. Typically, they'll have proximal to distal loss, and typically it'll present a little bit like a spinal injury, where anything below where that neural tube didn't develop, they won't have motor, nor will they have sensation. Now, obviously, it can be incomplete or it can be a complete loss. The more complete it is, the more it'll affect abilities, skin integrity, postural awareness. We also find that some of the spina bifida clients also have cognitive deficits because of hydrocephaly, because of other central nervous system problems during development. But very typically from their trunk and above, their upper limbs, their trunk control, their head control will be normal or near normal. Spina bifida can collapse in the frontal plane, okay, because typically, sorry if I didn't say before, typically we'll have low tone in our spina bifidas. So they typically will have low tone versus a spasticity high tone sort of presentation. So we can have a collapse in that frontal plane, or I could also have a collapse in the sagittal plane. Okay. In terms of the evaluation, all the things that we talked about earlier in the webinar, but we want to think of in sort of diagnosis specific terms. What do we anticipate for growth? We know all kids grow, but with spina bifida, it's more likely to happen in width than in height. So we'll want to bring a little bit more seated width growth into the chair as opposed to depth growth, typically. Do also remember when we're talking about growth that we've got a segment between their lower limbs and their trunk. So if you're sort of building in 2 inches of depth growth, that's 2 inches of femur growth, but they'll also, in a ratio, grow about 3 inches at their trunk and about 2 inches at their lower limb. So if we do the math, if you build in 2 inches of seat depth growth, that's actually 7 inches of overall height growth. Okay. So my point here is don't build in too much. Plus, a lot of our pediatric chairs anymore, they have the growth, the change built in. so that you can get it at the right side today and still have that growth. As I said before, a lot of these spina bifida clients will have cognitive deficits. They may have memory or processing or sort of understanding new environment, sort of cognitive issues. I found that a lot of my spina bifs, especially as I got to be 15, 16, maybe even 18 years old, they'd start to live independently and crazy things started happening to them. They'd fall out of bed. They would sort of forget to get the smoke detector fixed, and all of a sudden the fire department would be at their apartment. They would tell you they're able to do the right things. They would be able to recite to me how to do a safe transfer, but in the actual execution, sometimes it was a bit trickier. Skin integrity is a big concern in many of the spina bifida population. They do not have sensation typically, and a lot of them have bladder bowel issues. So those two things lead them into a higher risk category. They're also less able to do a good pressure relief, sometimes because of the width growth and their overall weight. So just make sure you're watching skin integrity and putting them into a higher risk category than some of these other diagnoses. Typically, they'll have a low tone presentation, but again, that can be low tone that sort of collapses in either the frontal or the sagittal plane, or both, okay, which would lead to obliquities, scolioses in the frontal plane, and kyphoses in the sagittal plane. Special needs, along with assistive technology, their tablets, their iPhones, their smartphones, they also may have AFOs or their braces on their lower limbs. But very typically, I would expect the spina bifida population to be able to self-propel an active wheelchair, at least when they're young and able, or an active wheelchair with perhaps a power assist. So in terms of the mobility sort of category and what we're considering, we really want to be able to maximize their ability to propel. So configuring the chair so they have appropriate access to the wheel. You'll want to consider seat slope. You want to consider making sure the tip of their middle finger can come to the center of the wheel. Make it as lightweight, as durable as possible. You'll also have to make sure that the seat to floor height so they can maintain independent transfers if that's what they're doing. Often I'll try and simplify this equipment, again, just because sometimes that cognitive involvement and inability to sort of apply new principles. If they're wearing the AFOs or a brace or bringing crutches, perhaps, make sure that you can accommodate. Those can come along. Do consider power assist or power mobility. If they're not doing all the things that they have the potential to do, maybe it's just taking too much energy in the morning and they're really fatigued by the afternoon, or it's limiting the places that they would go or the things that they would do. Okay. Many of these power assists are great for the spina bifida population. In terms of the overall goals sort of for the seating, make sure that you're creating a posture that functionally works, functionally for propelling, functionally for transfers. Also make sure that you're protecting their skin. They are in a higher risk category. If you do have any neural tube sort of spinal deformity, make sure you're accommodating that. I guess one thing I haven't said about the spina bif is sometimes they can come into an anterior sort of lordotic posture. Make sure that you're supporting that as best you can. And here's why this was his very, very first wheelchair. He was one of those kids that got on the top of the push rims and gave it 1000%. So we put this chair pretty darn stable. You can see that the wheels are significantly behind him and sort of limited his ability to tip over in the beginning. But we've given him good access to the wheels, a lightweight, growable chair, some pretty significant seating. We needed to create midline with those curves. So he's got a big pelvic obliquity buildup. He's got big thoracic laterals. And then because we were sort of being so aggressive with those asymmetries, we also needed some lateral thigh and lateral pelvic pads. and an anterior pelvic belt to hold those places and make sure that he stayed in midline. Okay, but it's a very changeable, adaptable, growable chair. Once he gets the hang of pushing this, we'll drop the rear seat height. We'll move the wheels forward and make sure that we make a really push-friendly chair. Remember that our goals for him will be independent mobility indoors, at school, and maybe facilitated assisted propulsion for longer distances or uneven terrains. Okay, but we've put some nice handles for mom so she can help him. They also went for a folding chair just because of how they transported. He gets out of this chair and rides in the regular car seat, and they fold this chair up and put it into the boot. And off he goes. Well, then look at cerebral palsy. And remember that cerebral palsy is more of a definition of their symptoms, really. It's really damage at the time or just before birth to something in the central nervous system. And it's really a series of symptoms or presentations that we put into this cerebral palsy category. But somehow that damage to the motor system has created a spasticity issue, either low or high tone. It's caused some degree of motor control loss across all the limbs or a portion of the limbs. And very typically, we'll see communication difficulties. We may or may not see sensation loss, and we may or may not see any cognitive impairment. Sometimes I think these kiddos are smarter than we are. So we really need to facilitate getting them engaged and allowed to be interactive in their environment, and also the ability to communicate. In terms of the spastic side, they can be a quad or a hemi, a diplegic or para, so depending on which limbs are involved. We can have lots of big, slow movement, sort of dystonic movement. We can have rapid, low velocity sort of movement, which would be the ataxic presentation. Or we can also have a generalized low tone in 1 or 4 of the limbs. When we think about cerebral palsy in terms of these evaluation categories, with growth, typically, especially if they have a lot of spasticity, they're burning tons of calories, I'll think about making sure that I have more depth growth as compared to width. Cognition can or may not be impaired, so make sure, again, that you're facilitating what potentially they might be able to do. What are their able-bodied counterparts doing? Can we come close to matching that? It is classified as a non-progressive neurologic disease, so you're not losing neurons or central nervous system parts. But we all know that over time, posture can worsen, tone can change. And basically, getting heavier, spending more time in gravity, having higher spasticity can make it seem like it's progressing. We know that spasticity is impacting their posture, so their asymmetries may get bigger. Also, just muscle strength definitely changes those asymmetries. And again, it can be in multiple planes or just one, but we'll typically see obliquities at the pelvis, a scoliosis at the trunk. We can see a kyphosis of forward head, but very typically we also see both pelvic and trunk rotations. In terms of the special need categories, oftentimes we'll need a communication or some sort of tablet for their communication that needs to come on board. We could also have any sort of GI or respiratory equipment. Also bracing, orthoses, or second skins. Again, that category that's helping to influence their posture and their shape. In terms of mobility, really depends on their presentation, whether we're looking at a manual chair or a power chair. If it's meant to be a self-propelled manual wheelchair, again, make sure that it's as lightweight as possible with child-appropriate components. Make sure that you've maximized propulsion efficiency by where the wheel is placed, the seat slope in the system, that you've given them access to the wheel locks, to the, the components that will facilitate their independence in their ability to choose where they're going. If it's a power wheelchair, make sure that you are building in change. Kids do grow. So modular in terms of seat size, seat width, seat depth, back height. Also maybe looking at powered seating. Would they really benefit from tilt and lift today? Will they need recline in the future to manage diaper changes, for rest, for management of any seizures? So think about the powered mobility system in terms of where they're going to take it, obviously how they're going to transport it, and then think about the growth, the ability change that you need to build into both the seat frame and in any of the power seating components. With cerebral palsy, I'm probably a little bit more lenient, if I can say that. I really want to create a functional posture. And sometimes that's going to be a little bit of asymmetry. And I'm okay with that as long as, it's not impacting their skin integrity, as long as I haven't taken away their ability to breathe, swallow. And hopefully I can undo that asymmetry that I'm doing in their mobility device while they're sleeping. Right? CP is really one of those populations where we need to look at the 24-hour clock and use sleeping maybe to undo some of the asymmetries that are growing in their active postures in their wheelchairs. Okay, so make sure that you're finding a right balance between a posture for function and comfort and a posture for symmetry. Although they won't have neurologic deficit increase, their symptoms most typically will increase. So make sure that you're building in adjustability change for not only growth, but a change in ability and function. Okay. So whether we're talking about a little stroller early on in the piece, or when we're starting to transition into a wheelchair, where are they going to take it? How are they going to transport it? What will they encounter in these places? What types of terrains? What type of distances? Who's going to push it? What do they need to get through? What do they need to get underneath? Okay, all those sorts of questions. Create your priority list, create your goal list, and that'll help you decide what chair is most appropriate to trial. Here we have a young lad, not in a wheelchair, he's in a tumble form. Tumble form really isn't providing any sort of postural support. This is little Isaac, he's 15, these pictures. So for him, obviously our main problem is his head position. This is at the end of the day, this is sort of worst posture, but he typically come 3, 4 o'clock, this is how he would end up. Okay, so we really needed to have some postural supports help create a better posture for him, a more sustainable posture. And he also had no mobility here, even though he's never going to be able to push a manual chair by himself or a power chair, but at least his caregivers, his family can move him around, take him to new places if we get him into a mobility device. Okay, so when we look at sort of our problem list here, obviously it's the head position, and he's got lots of shearing, lots of high pressure issues on his sacrum. We want to improve, bring a more upright posture, and have him be able to be more included. And so for him, because he's sitting the majority of the day, he's not able to do a pressure relief. We want him to be able to engage and participate to the best of his ability. We're going to go with the tilt in space wheelchair. That's safest for him in terms of posture management, in terms of skin protection. It's also safest for his family to get him a resting position throughout the day versus having to get out of the chair. So we are using that tilt in space wheelchair with a solid backrest that's promoting thoracic extension. We've got an ischial shelf J-fusion cushion so that we're holding that pelvis into neutral. Trickiest thing with him was head control. So we're using, sort of a static tilt of about 10-15 degrees, and a large adjust-a-plush headrest. Adjust-a-plush because we can change it along the way, and that's giving him that postural stability. The tray is also giving him some postural stability as well as a fun surface for toys and engagement inclusion. We probably don't see osteogenesis imperfecta a lot anymore, but just in case, remember that osteogenesis imperfecta is a really diffuse fragility of the bones, and they often grow in lengths and shapes that are unlike normal bone shapes. They're also a very sick population. They'll have fevers, stomach ailments, just general malaise is sort of how I would describe it. The bones, because of their fragile, are very prone to fractures, and also, like I said, deformities, sort of asymmetries of the long bones. Some will also have pretty vast hearing and vision impairments. And so then when we look at what we're trying to provide for osteogenesis imperfecta, it's really about mobility, functional mobility, comfort, and protection. Very typically, we'll put these guys into a power wheelchair just because longer term, that's much safer, much more functional. But if you were to consider a lightweight manual chair because of transport, space issues, family issues, make sure that it's lightweight, it's easy enough to push, and that you've protected. So very soft arm pads, brake extensions, pad the frame so that you can just keep those bones as protected as possible. Definitely within the seating, we want to create a posture that's comfortable and safe. We also want to make sure that they're tolerant. They can sit in this chair for the length of time that they need to. Okay, so think soft, contoured seat and back. Think softer arm pads. Think frame protectors. Also, in terms of a power wheelchair, you want to make sure that if you anticipate them driving, that they'll need to have access to that joystick in a functional and a safe location. Let me go back one picture. Her joystick is a little bit out of the picture here, but very close, and it's also on a swing in mount so that when she's driving, it can be right at her belly. It's very, very easy for her to access. Soft, a little foot box here because of her misshapen and short legs. Just a little happy home for her legs to be. She's safe, she's supported, and quite comfortable and mobile. Acquired brain injury, and by acquired brain injury, I'm specifically talking about that pediatric population that was developing normally and then had a traumatic event, that sort of a brain injury. Here with ABI considerations, we really want to get them back on track so that we can think about age-appropriate independence, so depending on the level of the injury. But can they be mobile? Can they begin to be included and engaged again at school, in family life? Think about accommodating any deformities that might have been due to the actual accident or incident. They're growing rapidly. Make sure that you are able to adjust to any sort of shape, size, and also ability. So modularity is very important with ABIs. I find that a lot of times when you've had this sort of an insult to normal growing kiddos, that all of a sudden they get sort of really crazy asymmetries. So just be on the lookout so that you can support as their body, their ability changes. Here it's a sort of 50-50 split. You really want to create some symmetry so you don't get a lot of obliquities, scoliosis down the way when they're 15, 16 years old. But also you want to make sure that they're able to participate so that you've got that posture for comfort. And always, sort of like with every diagnosis, you want to make sure they can tolerate sitting for the length of time that they need to. Okay. And then you have muscular dystrophy and sort of your SMA population. And lumping these together for some of these early slides, both MD and SMA are hereditary progressive motor neuron diseases. Duchenne's, we find, is more prevalent among males than females, sort of depending on the type that they have, but more typically than not, we find a slower progression. These kids are walking, and then all of a sudden it becomes harder to walk, and maybe they use an assistive device before they, sort of in their teens or late teens, might progress to a wheelchair, or more commonly a power wheelchair. Obviously, every presentation is a little bit different. Some may have very rapid spurts of progression. Typically, it's a proximal to distal lost. And you have to remember that their sensation remains intact. So comfort is very, very important. SMA, or spinal muscle atrophy, more typical in a female than in a male. And with SMA, we generally find that the progression is much quicker. So by their teenage years, they're pretty involved, and type 1 even quicker than type 2. And with these guys, their sensation remains intact as well. So comfort, stability, getting out there and doing is really important. With muscular dystrophy, I tend that the growth is going to happen in width more than in depth. So when you're anticipating how much growth to build in, think there. I find that the majority of these guys are smarter than we are. So getting them engaged, getting them active, able to make independent choice about where and what they want to do is important. Here we really have to create the balance between a comfortable, easy to get into posture, but one that's sustainable, right? We have to manage obliquities, scoliosis, even our SMA populations, and sometimes our muscular dystrophy, they come forward into a really anterior pelvic tilt and some lumbar lordosis, which is really hard to manage if they get so far in front. There's not a lot of postural control that we can add. So especially early on, really try and create midline as best you can. Typically, it's going to be low tone, and remember, as progression happens, they're going to have less and less control of their limbs. So again, really trying to find that balance between a functional posture and a symmetric posture. These are the diagnoses, or the kiddos that may have lots of stuff coming with them. A suction machine, an oxygen tank, a bilevel, a CPAP machine. Maybe on feed tube, they definitely will want their computer and their tablet and their iPhone. And by the way, they want to charge it as well. So again, you can capture all that information during the assessment and make sure that you can build it in to their power chair, or maybe even their manual chair. Depending on the age, we may start with a manual wheelchair. Just make sure that you're making that as functional to use as possible, with lots of adjustability built in. Same thing with a power chair. Make sure it's modular, that you can change in size and in shape. Be ready to have power seat functions included. Well, they'll definitely benefit from tilt, but would they also benefit from lift in terms of access and education access? Might they need recline to help with bladder management or rest? Might it be a standing chair so they can get some weight bearing, some standing functionality? In the end stages, do they need any of those respiratory pieces of equipment, maybe even a vent? Okay. And seating, again, it's just that nice balance between both a functional and a symmetric posture. And it's a really nice outcome for this muscular dystrophy young man. Nice balance between a posture that's easy for his parents to get him into, but allows him also to have relatively symmetric posture. And also he's able to get that joystick and maintain that joystick. For him, it's all about the power seat functions. He needs to use tilt to take the pressure off of his bottom. He also has recline for just very small incremental changes that really helps him with his comfort. Also think about expandable, changeable electronics. So if he loses functionality in that right hand, can we switch it to another type of control or to another place for control? So that little kiddo that we saw on the pillows before, obviously low trunk control, low tone. How can we create a nice posture for him, get him included, engaged? So doing a bit of, a body segment range of motion assessment here, looking at where he gets engaged, where he gains head control. And with these kiddos, when they're very young, we really want to create postural stability and symmetry. Obviously making sure he's comfortable so that he can sit there for a couple hours and be engaged in other fun activities. Really at this stage, it's really about allowing him to engage, get active, be part of the family, be part of the school. And obviously at this stage, he's going to be dependent. He's not going to be pushing a manual wheelchair. So we've gone again with a tilt in space, a dynamic tilt in space, so he can get rest, relief from gravity, and skin protection. Here we've used a pediatric zippy iris, a J3 backrest with a nice wraparound hug to keep him in midline. A GS cushion, again, I want that ischial shelf so I can keep that pelvis in neutral. He had a little bit of extensor sort of tone, so it just allows us to keep him in place, nice and stable, so he can play to his heart's content. A lot of times we say we want to tilt in space because of skin protection, but remember, especially in these pediatric clients, it's a lot about helping with posture, trunk control, head control, allowing your laterals, your postural pieces to help you because gravity isn't working against you. And it's also a place of rest, of relaxation. Okay. And then this one little kiddo, very young SMA young lady, born very, very early, very switched on family, realized that, boy, we got to get some mobility devices to get her active and engaged. But again, even at that very early stroller level, we needed to create that midline position, but in a simple, growable, this is the little Voyage stroller. Off she went, included with everything. Here we just want to influence, create a little bit of a lumbar lordosis, a little bit of a thoracic kyphosis. Make sure she understands where her body is in space. She's learning so rapidly. Make sure that we're creating nice neutral symmetry of her posture, but allowing her to be included, really. A lot of times parents at this early stage just want to have a regular umbrella stroller. I understand that. So let's make one that is a collapsible, easy umbrella stroller. Yeah, works just like a regular able-bodied stroller. You can have your coffee cup, you can have your brother tray on the back, or little footstool on the front, all that stuff, storage underneath. But then within the seating system itself gives us the postural components to create that midline posture. Okay, but easy to use. Okay, so that's what they did. But then as she got older, obviously they wanted her to continue to be, or to become really independent in choice, figure out where she wanted to go. Cognitively, she's smarter than we are, vision's great, so let's go straight for power. Started with a power chair trial. Some switches is typically how we'll start in a mid-wheel drive chair, and she got that quite quickly, quite rapidly. We'll tend to use, if we're going power mobility with pediatrics, we'll do mid-wheel because it turns where they're sitting. It's got the smallest turning radius. It's really the easiest to learn. With her, it's important that we have a growable seat frame. She's gonna change inside. We really needed to do tilt so that she could have that rest and relaxation and pressure management. She's a go-getter with the joystick. She's got full control there. And in fact, we've just started some Bluetooth and IR integration so that she can tie that into the controls of the TV at her house, sound system at her house. Her parents also have an attendant control for behavior management like a normal kid. And also they assist her when she's outside. And off she goes. But a really usable chair gives her independent mobility, but it will change with her. Her disease is going to change quite rapidly. Her size will also change. Okay. Little Cyrus, he was born prematurely and sort of a whole vast of chromosomal mutations, very low tone, and no head and trunk control when he first started. And just like we were talking about with Emerson, the really early stages here, it's about making sure we're creating the normal curves, symmetry, but in a fashion that's easy so that mom and dad family will use it. He gets to come with them. He's going to the grocery store. He's going to develop by being included in all those normal activities. But we want to do it in a way that's safe, that we can really create those normal body curves. Okay, and that's what I like about the Voyage so much is, his parents just see it as a really nice stroller that works. I see it as a postural device that's really creating the foundation for him to have a nice life. Okay. And then last one, we have to take care of this young little lady using an umbrella stroller as not only, her mobility, but also as the shopping cart, and found that she just got sort of left in the corner and really wasn't included. We're creating a lot of kyphosis, really having trouble with management of secretions, with management of head control, all those things. And I guess we hopefully at this point know that we're going to put her in a dynamic tilt and space chair, right? We want to have some nice postural support. So she's got a good midline trunk position. Those laterals are helping us there. But what's really helping us is we have a pretty strong sacral block, and we're creating a little bit of an open back angle, a little bit of back extension there so that she can have better control of her head. She's also much more able to take a deep breath, participate. Look how much more engaged she is. With all that support at the backrest, I need a cushion that will hold that pelvis in shape. Okay, ischial shelf, some lateral contouring, some medial contouring. She's obviously going to use that tilt in space, a little bit of tilt in the static position here to help control that pelvis, control the trunk position, the head position. I find with a lot of these trays, I'm going to call that an upper extremity support surface, because that's really helping me create some thoracic extension, some better breath space there. Of course, it's also a functional surface, but it's really helping me with posture. A positional head support, all of those things really creating a great posture, but also in a growable, user-friendly chair that the family is really going to appreciate. Okay, as she grows, as she gets bigger, we're going to be much better able to control her posture, much more able to have her be included in family activities, in school activities. Okay. Hopefully that was helpful, going through by sort of diagnoses, what we expect, what we anticipate, and what we need to provide in terms of not only our seating system, but in our mobility device. Obviously, all of that is altered by, sort of that assessment and what the family goals are, what the must-haves, what the problem list is. So that's always your first starting point. As always, we really appreciate you attending. Any questions, reach out. That's my email address. If you would like any assistance or another set of eyeballs on any of your particularly tricky clients, feel free to reach out. Until next time, have a good one. Be safe. Bye-bye.